I'd like to welcome everyone to the PARC Seminar for May. For those of you who are new to PARC, PARC is a transdisciplinary center spanning UCSF clinical and research communities to advance pain and addiction science and care. You can get more information from this QR code.
Decrease 1 iota, because how could anyone resist that?
Howard, I think, yeah. This is our last seminar for the year, but we will be resuming in the fall. So keep an eye on your emails for announcements. And if you have any suggestions for speakers for the upcoming year, please let us know at parc@ucsf.edu. Our speaker today is Dr. Tauhidur Rahman. He is at UC San Diego. He earned his bachelor's degree in electrical and electronic engineering from Bangladesh University of Engineering and Technology. He has a master's in electrical engineering from UT Dallas, and his PhD is in information science from Cornell University. He's currently an assistant professor at the Data Science Institute at UC San Diego and director of the Mobile Sensing and Ubiquitous Computing Lab, or the MOSAIC lab there. They design and develop on and off-body sensing systems for modeling health and behavioral outcome measurements. And they utilize applied physics concepts, specialized signal processing, and machine learning algorithms to investigate digital epidemiology, substance use disorder, mental health, and sleep. And I'm excited today to hear about what he's been working on in the substance use disorder field.
Wonderful. Thank you so much. Thank you, Elisa, for the wonderful, kind introduction. So let me share my screen. All right. Is my screen visible to everyone?
Yes.
Yeah, you'll need to go to a full presentation.
Yeah. Perfect.
Great.
See it. I don't know if I do this, do you see my presenter view or do you see the full slide?
So we see the presenter view now.
Oh, okay. Yeah, we don't need that. All right. So yeah, once again, thank you so much for such a kind and wonderful introduction. And thank you. It's my honor to be here, actually.
We still see the presenter mode instead of the full screen.
Oh. Okay, let me.
Yeah, you got it.
Is it better now?
Yes.
Okay, let me. Full screen, right?
Yes.
Okay, perfect. Thank you so much. And thank you so much for the kind introduction. My name is Tauhidur Rahman, Director of the Mobile Sensing and Ubiquitous Computing Lab here at UCSD. I have a joint affiliation, so primarily affiliated with Halıcıoğlu Data Science Institute, but I have also affiliation with Computer Science and Engineering. So in my lab, we, broadly speaking, we try to harness health signal with large-scale mobile sensor data for a variety of fields. But more recently, one of the major focus has been modeling substance use disorder, and that is exactly where I'm gonna focus today's presentation. Before talking about, let's talk about mobile sensor data first. In recent years, we have seen a rapid expansion and growth of mobile sensor devices in our daily lives, and that is purely because the ubiquity of various mobile sensors in many of these mobile devices that are out there. And we have seen, if you look at the recent trend, both coming from academia and industry, you'll be able to see that mobile sensor data can enable next generation healthcare by fundamentally defining how we monitor health condition, how we track effects of treatment, how we detect incidence of diseases, and trigger just-in-time health intervention. Now, the question remains, there's still remaining questions, right? What is behind this resounding success of mobile sensor data systems? And if we look for the answer, what we'll essentially find is it's nothing but the mobile sensor data enable digital biomarkers. In fact, in recent years, we'll be able to see that many of these on-body sensing devices, like wearables, like Fitbit and smartphones, and thanks to the availability of some of these internal sensors that are there, they have been successfully used to develop digital biomarkers that can capture internal physiological and behavioral processes. However, there's still gaps. We still lack in the ability to create these new informative digital biomarkers that will be able to capture early indicators of different syndromes, right? The emphasis is on leading indicators. By the way, on my end, I can see my internet is unstable. Is it? You can still hear me fine, right?
Yes, it's good.
Okay. Sorry. So essentially what I'm trying to say is that there has been a major gap in creating early leading syndromic indicators. And unless we have these early leading syndromic indicators, we'll not be able to use many of these digital biomarkers to trigger just-in-time intervention, or it may not really be valuable for early detection either. So earliness is essentially one of the big factors that where we need to work on. Now, so far we've been talking about individual level sensing, right? Where the focus is to track or model individual level health outcomes. If we steer our attention from individual level sensing to population level syndromic sensing, we'll see different types of challenge. And one of the major challenges there is the scalability challenge, right? And the fundamental idea is that if a large portion of this underlying population that we're trying to model, right, either do not have access to many of these mobile devices or do not feel comfortable sharing data with a centralized data center, right, the resultant aggregated population level signals that we get from all of these mobile devices, right, from the target community will not be reflective of underlying population anymore, right? So essentially, we will be left with this low signal to noise ratio signal, which will fundamentally limit our ability to make data-informed, effective community level disease forecasting, just the way we do weather forecasting, for instance. And these are some of the challenges that we try to tackle in our research. And the vision for our research in our lab is to develop this smart and connected mobile sensor data ecosystem for sensing early health indicators from individuals and communities at scale for generalizable and accurate predictive analytics, right? Quite mouthful. Let me simplify this text by highlighting three key terms, which are essentially early health indicators capturing earliness at scale, indicating that there needs to be the mobile sensing data ecosystem that we're trying to propose needs to be scalable. And obviously, generalizability and accurateness captures the correctness metric, which is a primary requirement for creating such a system. Now, however, and these three key terms essentially three key design choices when it comes to creating any smart and connected mobile sensor data ecosystem. However, these three key terms doesn't go hand in hand. Many times there is this trade-off relationship. Many times, in order to, if we achieve one of those, let's say correctness, we have to, we have to adopt a more obtrusive version of this sensing system. Let me illustrate it by with this conceptual diagram in this three-dimensional hypothetical space with respect to unobtrusiveness on the x-axis, correctness in the y-axis, and kind of earliness on the z-axis, right? Now, if we map the state-of-the-art hospital technologies, we can think of all the technologies that are available in an ICU setting, for instance, right? They're designed to be highly correct, right? However, since they're primarily used at the not those technologies are not really ready to be used in a home setting, or those are also highly unobtrusive in nature, they will get pretty low score on those two dimensions, right? So they'll get a high score in correctness dimension, but not so high score in unobtrusiveness or earliness detection. On the other hand, if you look at the state-of-the-art mobile health sensing solutions that has been designed for personal use, right? You can think of Apple Watches and Fitbit and smartphone and all of those, right? They're designed to be highly unobtrusive in nature. However, due to lack in the sensing mechanism that I just discussed earlier, their earliness and correctness score is not as high that we would ideally like it to be. So the fundamental challenge that we try to solve in our lab is to create these new variants of mobile sensing solutions that can be used both for person and population level sensing that maximizes these three factors simultaneously and kind of pushes these dots to this northeast corner of this diagram, right? And with that kind of vision in mind, from a research methodological perspective, our research can be kind of divided into roughly three steps. We focus on sensor system development, which is then followed by signal interpretation, creating this signal processing, AI ML algorithm development, and lastly, implementation of this algorithm in mobile devices, right? So that it can be used in the form of a mobile app or a website and things like that. And with that kind of research vision and kind of methodology in mind, we have been doing many different research projects in the last 8 years approximately. And today I'm going to focus on a subset of research that will be primarily focused on substance use disorder. All right, so the photo that you can see on the screen is a difficult one to look at, right? It's a photo from a memorial service for a man who died of drug overdose, I think back in 2017 from Baltimore, Maryland. In fact, we have seen that more than 100,000 Americans died of drug overdoses as the pandemic spread across the country. And there has been a severe increase in pandemic-related mortality in the United States. It was the first time that the overdose death exceeded 100,000 per year, which was kind of more than the total toll of car crashes and gun fatalities combined, which are also serious problems that exist in our society. And in 2023, the overdose death topped to 112,000 in the 12-month period. And if you look at the state of the care, we'll be able to see a big gap. So and I think this is nothing new to you. You all are kind of familiar with these numbers. But I still wanted to have some of this slide just to highlight the gravity of the problem, right? To those who are perhaps not as familiar with some of these challenges related to substance use disorder. So in 2019, 21.6 million individuals needed treatment for addiction and substance use disorder, where only 2.6 million received any treatment whatsoever. So in order to really understand the challenges that we face due to substance use disorder, and many of this, it's important for us to realize that many of this mortality that we're seeing in our society is due to what we call opioid use disorder, a significant part of it. And in order to understand the opioid use disorder, we have to really understand the downward spiral of opioid use disorder, right? So again, needless to say to this particular community, but I had this slide for general slide for other community. So what is opioid? Opioid is a drug that binds to receptors in our nervous system and brain and provide temporary pain relief, right? However, recurrent use of this drug give rise to changes in our brain circuitry that give rise to attentional fixation, stress and negative emotion, rumination of pain, which in turn promote repetitive reinforcement of opioid use. And a subset of these individuals who has been prescribed with opioid may find themselves in this downward trajectory and essentially lose control over opioid use and develop this full-fledged opioid use disorder. What you can see is that repetitive reinforcement of opioid use can be thought as a leading indicator of loss of control over opioid use. And monitoring of opioid use can provide us an early warning mechanism for opioid use disorder, which can prevent misuse and addiction. Now, if you look at the current state-of-the-art opioid use monitoring systems that are out there, we can roughly see two camps. One is self-report-based techniques, which suffers from inaccuracies due to recall bias, intentional misrepresentation. On the other hand, we can see this biologic sample testing, right? Blood and urine testing, which are fairly invasive. They have a limited detection window, right? It can only detect like what happened in last 24 hours or 72 hours, and does not infer the precise timing of those use, right? And fails to capture give us any trend. So what we can realize is that there is no objective measure that exists to passively and continuously monitor opioid use. And in our recent work that has been published a couple of years, actually, I cannot say it recent anymore, we developed OpiTrack, a wearable-based opioid use tracker system with temporal convolutional attention network. On a high level, what it does is it's essentially a wearable wristband that captures these multimodal signals, including accelerometer data, skin temperature, electrodermal activity, which is also known as galvanic skin response, the interbeat interval, and then we can capture various cardiac metric, heart rate variability measures and heart rate. With this multimodal time series data, then systematically get processed by what we developed, what we call temporal convolutional attention networks, which then gives two outputs. It at first detects whether someone has used opioid in a particular 1 hour period. And if the answer is yes, right, then it tries to estimate exactly when within that 1 hour period the person might have consumed opioid. In order to train our model and validate our system, we have collected in total approximately 5,000 hours of wearable sensor data, capturing 566 intravenous and oral opioid administration in both hospital and home setting from about 47 participants. And the ground truth data for opioid administration was, in a home setting, it was collected through self-report, but in the inpatient hospital setting, it has been collected primarily by the nurse's log, essentially, and some of the information are also gathered from electronic medical record system. All right, so now before we started modeling, right, the challenge that we're looking at is we have to develop a model that will look at the physiological changes in that 1 hour period, and we'll be able to answer this question, these two questions, whether the person has consumed opioid or not, and when the person might have consumed an opioid over that 1 hour period. And then we'll shift the window and then ask the question again to the model, right? And then that will give us a time series output of opioid use. Now, before going into the modeling, we've at first looked into, we used statistical techniques to kind of analyze changes in wearable signals due to opioid use. And our kind of statistical approach revealed that different channels show unique modality-specific trends. For example, heart rate variability, temperature, and electrodermal activity features tended to increase, show an increasing trend from pre to post opioid use, whereas as you might expect, heart rate and accelerometer feature, right, as it's kind of a pacifier, right? The drug is kind of, opioid is a pacifier. Heart rate and accelerometer features tended to decrease from pre to post opioid administration. But although the individual feature achieved statistical significance, we can still observe the high standard deviation from on the error bars, right? Which shows that if we want to use any one of these features to develop a model of opioid use, will not be really successful because there are a lot of variability coming from pharmacokinetics, kind of biomedical traits of that individuals, and things like that. So what we really need to be looking at is an effective mechanism to fuse all this multimodal data so that we can kind of compress the error bar and have a much more reliable variance of opioid use tracker system. And this is kind of our model. I'm not going to get into details, but on a high level, the depth-wise block, right? We have a series of blocks that systematically process this time series data. The depth-wise blocks extract features from each modality separately to capture unique modality-specific trends. And then we have attention block. In the AI ML world, if you follow those trends, this transformer and LLM, much of this is actually happening because of this attention mechanism. As in other words, this model actually now can kind of figure out how to distribute its attention in a time series data. In other words, if I give this 1 hour time series data, it knows, oh, I have to look at the time between, maybe I'm making it up, right? 30 minutes to 37 minutes were particularly relevant to making a decision about opioid use because of these unique changes that might have happened. So again, the channel attention block and temporal attention blocks learns to distribute the model's attention across multiple channels, multiple modalities that we have, and multiple time period that we have. Overall, our model outperforms all traditional machine learning models and statistical models trained on manually engineered features, as well as other time series models, including bidirectional LSTM and convolutional neural network LSTM, long short-term memory models. And we have about 80% F1 score, which is quite encouraging. And in this plot, we can see that a scatter plot between actual administration time and predicted administration time within that 1 hour period, right? And we can see that roughly all these dots are kind of distributed across the diagonal line, and a mean absolute error between actual administration time and predicted administration time was about 8.6 minutes, which is quite encouraging, right? Again, our model is not perfect, and we're going to systematically show where the failings of our model, but it's generally encouraging that, okay, something like this is possible where someone will wear almost like a Holter monitor for cardiac patient, right? So the doctor will share, okay, why don't you use this watch for next 2 weeks, lend it from the hospital system, and then come back and we'll look at the data and we'll see whether you have any kind of concerning trends on your usage behavior, perhaps. Now, talking about problems with our models is not without problems, right? We did look into potential bias. What we found out is our OP-track model performs significantly better for naive user, opioid naive user, compared to chronic user. In other words, right, this can be explained by the fact that repetitive opioid exposure can lead to opioid tolerance, right, requiring a higher amount of dosage to reach that certain physiological effect, right? And since we're essentially looking at the physiological effect to make the decision whether the person has consumed opioid or not, right, our model tended to be much better at opioid naive user, where the mean absolute error was lower compared to chronic user, and then F1 score, which is generally an accuracy measure, was slightly higher on the opioid naive user. And lastly, our model, we also looked into local explanation with gradient techniques, where our model, one of the main problem of the model was the black box model, right? And we looked into whether this model can actually, can we look in under the hood to really understand what is going on, right? What this model is actually learning. And with this local explanation with gradient technique, we can do that. And what we have observed is that our model puts significantly higher importance in signals around the actual administration. So here, the green dash vertical bar is actually the moment when the person actually intake the opioid, and the pink vertical dash bar is the predicted administration. So overall, it's good. It captured the changes. However, it also looked at, if you look at the second plot, you see that the blue bars, right, in the second plot, essentially the second subplot can be the second horizontal subplot can be thought as where our model is looking at as it making the decision. Essentially, it is paying a lot of attention to the electrodermal activity in this particular data point as it tries to make the decision, and so on and so forth. So overall, you can see that it's also attending to the right moment, which is around the opioid administration moment, like 10 minutes before and 10 minutes after the opioid administration moment. The model is particularly looking at significantly more as it making the decision. Yeah, the paper has been published, and it wouldn't be possible with my famous with my awesome collaborators. Big shout out to Stephanie Carrero and Brittany Chapman, as well as Jan Soquist. They were from at that time I was actually a faculty member at UMass Amherst in the computer science department, and I recently moved to UCSD in 2022. But we started collaborating with our colleagues at UMass Chan Medical School, and they have been super supportive. And this work wouldn't be possible without their support, period. All right. If you have any question related to that, you can, maybe it's a good time to ask. Otherwise, I'm going to move on. Or if you prefer to ask questions at the very end, that is also a possibility. No rush. Okay.
I have a question, just a quick
Sure.
clarification for those data that you used to train the model. Was that both oral and IV opioids or just oral?
In this particular paper, it was all oral or all IV. So that will show that is why the performance is so good. But I'm going to show the immediate next paper that I'm going to present is actually both. It extends its work into the oral world where things becomes much more messy and challenging. Yeah, great question, by the way. Fantastic question. It related to exactly linked to the next part of the presentation. So one thing to recognize is
There
that
is a question
oh, yeah.
that came in the
Oh, yeah.
chat from Joel.
Oh, yeah.
Was the model tested against instances where no opioid use was administered?
Yes, it was. We randomly sampled both, right? There were instances because we have longitudinal data set. So on average, our users were this opioid are viable for several days, actually. If you look at this plot, here each horizontal bar is a participant. So we have, let's say, participant 5 has used it continuously for more than 7 days, 7.5 days. So we have instances of both use and non-use, and that has been used to validate our model against. Great question.
Yeah. And one more from Christine. Do you need to control for dose of analgesic in the model and participant characteristics?
Great question, and directly relevant to the next part of the presentation, where I'll be demonstrating how we can actually incorporate pharmacokinetics information of different dosage and different types of oral opioids to train a better model. In this particular case, our objective, our hypothesis, right, was that there would be a model that will be able to detect all different doses, right? So we did not directly incorporate that, but you're right. By incorporating, if we know that, okay, these individuals roughly, generally, this individual has been prescribed with this amount, that will, I think, improve the model accuracy. But we didn't take that information into account while training the model. Great question.
And Mark asks, did you see tolerance development over the 7 days?
That's a great question. Actually, we did. I don't believe we looked into this particularly. That okay, as the individual repetitively take opioid over this 7-day period. But when we talk about naive and chronic, basically these individuals captured in the demographic information, whether these individuals have been taking opioid over a long period of time, whether a history of drug use, or it's something that just they have recently started, right? So based on that information, we kind of classified these categories. But this will be interesting supplementary work that'll be interesting. We didn't do that yet. Great question.
Okay, great. I think you can go on to the next part. Thanks.
Okay, thank you. Fantastic questions. All right. So, and then by this time, we started realizing that labeled data in substance use disorder field is extremely limited, right? However, unlabeled sensor data is cheap and abundant, right? Label is what makes it expensive, right? So the fundamental question that we asked is, can we pre-train our model with some sort of self-supervised task to learn better representation from large unlabeled mobile sensor data, right? So the idea was, before we teach our kids, right? I'm a father myself, right? Of elementary, my kids go to elementary school. Before teaching, let's say, I don't know, calculus, we teach them arithmetics, right? So the idea was, before teaching our model how to identify trends that are linked to opioid use versus not based on a physiological sense data, can we use some simpler task where it will be able to learn more about the multimodal sensor data itself and be able to kind of discern differences among these different modalities, etc. And what we also realize is that machine learning model fundamentally, black box machine learning model fundamentally lack physics knowledge, right? Especially some of the models that we have used, it has no idea of how physiology works, opioid-related physiology works, right? So a purely data-driven machine learning model may not learn underlying physics behind our body, behind how our body processes opioid, and it can miserably overfit and thus may fail to generalize across different types of opioid, right? And that also another last observation is that there's quite a bit of heterogeneity in the opioid space, right? There is this intravenous opioid, which has been designed to almost provides immediate effect, physiological effect, whereas the short-acting, long-acting opioid, long-acting oral opioid that has a much more prolonged period of time while they provide pain relief, right? So the question that we asked is that, can we integrate physical knowledge, the physics knowledge about how our body processes opioid during training phase by injecting knowledge? And is it possible that by injecting knowledge about opioid pharmacokinetics, we'll be able to train a more accurate and potentially more generalizable opioid use disorder? And I was not particularly trained in this area, so it turns out there is this is nothing new to doctors and physicians. Pharmacology is an age-old field, and there has been significant progress that has been made by that area. So by the time I was kind of learning about pharmacokinetics myself a little bit, and turns out that pharmacokinetics would provide simple compartment models and canonical equations to describe relative plasma drug concentration over time, right? They are, however, simplistic and have a lot of assumptions in it, right? Lot of coefficient that kind of assumes a lot of different things. But the question is, can you use it to train a better model that will be much more enriched, that have much more knowledge about the physics of opioid physiology? And we have done it in this work where we have developed pharmacokinetics informed machine learning model. And we train our model in 2 steps. At first, we kind of, the first step is the baby step, right? In the first training step, we created a set of artificial tasks, what we call artificial self-supervised task, designed based on pharmacokinetics of different opioids, where we artificially alter our large unlabeled data where there is no opioid-related changes. But by using pharmacokinetics equation, we emulate changes that might have happened due to opioid administration. So here we randomly select a window of data. We randomly select, okay, assume that hypothetically the person might have, let's say, have injected opioid at, I don't know, 30th minute. And then we simulate the changes that the participant might have observed in the physiology. And then we ask the model, hey, model, can you tell me whether the signal has been modified through our opioid emulation process within the synthetic data? And can you tell exactly when the modification has had happened, right? So the model is essentially learning to at least solve some baby problems first. And then we actually, with our limited label data, right? And the prior step has been done with a large data because we do have access to a very large unsupervised data set. And the next step, we have done it with our label data, where we force it to answer, obviously, these 2 questions, which is, can you tell me whether within this 1 hour opioid has happened, opioid administration has happened or not? And also, can you tell me exactly when the administration might have happened? But also, can you give me the plasma concentration based on a compartment model, the pharmacokinetics compartment model? Can you estimate it? What is the equivalent plasma concentration might be within this 1 hour period, right? So what this does is the model not only has to answer those 2 questions, whether the opioid administration has happened or not, but under the hood, it also needs to learn these compartment models that will force it to learn the changes of plasma concentration that are over time, that is plausible within the realm of physics, pharmacokinetics, essentially. And once we do that, what we observe is this pharmacokinetics informed model, the same model that we have used before. Once it has been pharmacokinetics informed, it significantly outperforms the baseline model that we have just demonstrated in the previous piece of previous project that I presented. And as you can see, the blue dots are, these are all oral administration, both collected in inpatient and outpatient settings. And as you can see that this, the brown dots has been much more scattered, and the blue dot is now coming closer to the diagonal line, which you want, because this is a scatter plot between actual administration time and predicted administration time. And which has also been reflected by R-square value and MAE. MAE also shrinks and R-square value improves from what we had before. So overall, what we observe is that pharmacokinetics actually significantly improve the work. And this work has been published in a couple of top tier CS and digital medicine venue, including NPJ Digital Medicine. All right, so far between the two work, essentially, hopefully, I could kind of, to some extent, convince my audience here is that we have created, at least we have attempted to create an alternative where we push this orange dots in this hypothetical three-dimensional space, which has limited correctness, earliness, and unobtrusive profile. And hopefully we have been able to create this new dot, right, in this technology space where this variable-based OP track could provide early indicator of OUD, moderately high accuracy, and it's completely passive and continuous. It doesn't depend on self-reports or biologic sample testing. Any question from this part of the presentation? Okay.
Mark,
Yeah,
here, quick question about whether you did a training with the administration of some other medication that's not an opioid, and made a comparison, as a control, as an active control. Thank you.
Yes, that's a great question. We did in the NPJ digital medicine paper, we did look into these individuals were taking other medication. Several of them has been prescribed with other form of medication, other pain medication. And in the NPJ digital medicine paper, we particularly look at whether our accuracy, what was our model accuracy in the presence of co-administration with those other medication. So let me, I know I didn't answer your question in a direct way, but two observation. One is we did have simultaneous administration of other drug present in our data set, this 5,000 hour of wearable data set. And secondly, we did analyze the performance of our model when what was the performance of the model when the participant has taken other types of drug with opioid. So we did that type of analysis. But I think naturally, since many of our window that are not representative of opioid administration would be representative of non-opioid related drugs. So yeah, that bit I can tell.
Peter, you posted a question in the chat. Would you like to ask it?
Sure. George Koob, amongst others, has famously addressed some of the factors underlying relapse in terms of craving and urge. So I was just wondering whether the parameters that you're monitoring give you any useful information as far as overactivated stress circuits, compromised reward system, and dependence-induced reward dysregulation. And if so, how are those being accounted for physiologically?
Fantastic question. In this work, we mainly focus on just use, but in the future work that I'm going to present, I'm going to show how we can actually, we developed stress, pain, and craving models with wearable data. using similar mechanisms, which then has been used to model opioid misuse. I'm going to present it in a bit. In this paper, these I think these individuals naturally has like their stress circuit has been triggered. I can tell, right? During the inpatient unit, they're at the hospital, not in a comfortable home setting, so they were most likely stressed out. But we did not actively take those things into account as we try to model opioid use in this particular case. So those are basically omitted, primarily because I think because convenience reasons, right? We wanted to create a generalizable model that will just directly map physiological changes into opioid use, right? Almost like a Fitbit step count, basically. How many times this individuals might have taken opioid. But I agree that those might be additional confounding factors that probably should be accounted for as we try to model, but we have not done that in this particular work. But I'm going to show you.
Yeah,
how
great. Let's get to see the next part.
Yeah, and this is exactly, I think, going to Peter's question, which is other factors, right? Now, what we realize is that opioid use tracking is fundamentally not really adequate for just-in-time intervention, right? By the time the person is actually administering opioid, it's oftentimes too late for any intervention to take place, right? And basically this famous opioid kind of loop goes on, and it becomes more difficult for these individuals to break out of these circles, right? However, if we had a mechanism to detect craving moments, right, it might be an optimal moment for triggering just-in-time intervention, and through that process, hopefully the subset of these individuals will break the loop and get out of the addiction kind of loop. In fact, in our downward spiral diagram, we can also see the downward spiral model of OUD. We also observe that several effective states that capture early trends within this downward spiral of OUD, including pain, stress and negative emotion, and craving, which are very important and fundamental when it comes to modeling OUD. And back in 2019, with some collaborators at Yale Medical School, Bob Mallison, I'm pretty sure many of you might know, unfortunately passed away during pandemic. And his kind of a trainee, assistant professor, but his kind of the person under Bob, Gustavo Angarita. We started collaborating with them. They had an R01. I was a new faculty member. They said, okay, we have published enough papers on this. We have a large data set, figure out what you can do. And I was a new faculty. I was glad to get this data set. And it turns out, and what we developed is this on-body sensing of cocaine craving, euphoria, and drug-seeking behavior using cardiac and respiratory signal. Essentially, what we have demonstrated in that particular paper that has been published in 2019, the simple morphological features of cardiac and respiratory signal can predict craving with a normalized root mean square error of 17.6% and with a Pearson correlation coefficient of 0.49, which is pretty encouraging in that preliminary work. And at that time, it was pretty old R01. They have used this Zephyr bioharness chest band to capture these bioclinical features, these cardiac features. And what we also found out that cardiac signal contained actually significantly more information than breathing signal. But more recently, we have pursued this paper where we have developed this personalized prediction of stress, pain, and craving within some sort of dynamic branching mechanism-based hierarchical deep learning model for opioid. And it was done with my colleague, Eric Garland. He was at the time at Utah, now recently moved to UCSD, and our colleague, Catherine Hansel and Madalena. So now, essentially what we have done is that when it comes to modeling effective process, right? Things like, as Peter was mentioning, craving, pain, and stress, these are highly individual in nature, right? The things that give rise to your stress might be very different from my stress, right? The things that triggers craving for another individual, right? A participant might be very different from perhaps my cravings, right? That I have in a daily life. So it was what we realized early on is it was particularly important, more than the opioid use. It was more important when it comes to modeling affective states, to build a personalized model. And what we have done in this framework is this: we developed, and what we also realized is just incorporating demographic information is not enough, because demographic will allow us to give some information about maybe my socioeconomic status, I don't know, my ethnicity and my age and BMI, etc., which would be important to some extent, but it still fails to capture a large part of information that are preserved within the physiology itself. So what we realize is that we create this learning to branch mechanism. So each of these blocks within this diagram can be thought of different processing units that captures different group behavior. So branch 1 would be a particular group, branch 2 would be another particular group, branch 3 would be another particular group within my digital neighborhood, right? Imagine that we create a graph of every single individual, right, that we have in our data set, and put them in a graph. And in that graph, we will have certain individuals in my neighborhood, but another participant will have certain other individuals in their neighborhood. And can you create these different branches that will capture this grouping behavior of different groups within my digital graph diagram? And then what we essentially want to learn is that for a new subject, as we join a new participant, as we try to solve the problem of stress, pain, and craving models, inferences for a new user, what we essentially need to find out is that which group belongs to which branches. And then this theta essentially parameters essentially learns this branching weights that learns where to branch from, right? In terms of user one is most similar to, maybe it should be belong to branch 2, and user 5 maybe belongs to branch 1, and so on and so forth, right? So that participation metric is captured by the theta behavior. And what we have found out essentially on a high level is that once we learn this digital neighborhood and my immediate grouping behavior in the cluster diagram, right? Our model tends to perform particularly well, and it performs particularly well when in a cold start setting, particularly when I didn't give a lot of label data to my with the model, right? Because if I give a large amount of label data, then it's possible that we don't even need other people's data. We can build a completely personalized model. But especially when I have maybe shared 5 stressful moments with my model, the model is not that 5 stressful moments with the physiology may not be enough for the model to actually learn how to map raw physiology to stress values, right? So it's particularly valuable to use other people's data in my digital neighborhood, and that way we build a much more robust model. Again, I'll be happy to take questions later on if there's any. But what we found out is just appending demographics, which is the state of the art technique, right? People think that, okay, just by appending demographic information, that we're pretty good. That tends not to be very useful. While learning this kind of digital neighborhood within the large graph space becomes particularly useful, and our dynamic branching technique performed particularly well, both for stress, pain, and craving inferences. And lastly, what we have asked another question, which is, can we think of this downward spiral as a nonlinear dynamical process of pain, craving, and stress? Is it possible for that individuals who will have a tendency to misuse, right, will show different trajectories of pain, stress, pain, and craving than from individuals who will just stick to the prescription opioid and will not misuse? Is it possible that by unboxing the trend, in a nonlinear dynamical process, right? By modeling pain, craving, and stress in a nonlinear dynamical manner, we'll be able to understand what is going on, and that will give us additional clues that will differentiate between these two groups, which are prescription user and potential misusers, who needs more help potentially. And that is exactly what we found out. We found out that the Taken's embedding trajectory of all the affective states revealed that the prescription opioid users' affective processes are significantly more unpredictable or chaotic compared to the misusers. In other words, regular prescription users' stress, pain, and craving trajectories over days, we're talking about multiple days, right? They're much more unpredictable. The way I think about it, their life is impacted by many different things, right? Interaction with kids, tantrum, I don't know, interaction with partners, work stress, a lot of different things stress them out. And the timing is pretty unpredictable. And sometimes it may not be easily modeled. Whereas potential misusers' stress, pain, and craving trajectories, we have found that they're significantly more predictable. Right? Their life essentially are kind of going around focusing on when the next time they could potentially, right, take opioid, for instance. And with that, we developed another model where at first we have this, what we just demonstrated, the stress, pain, and craving inferences, hourly inferences over multiple days, right? And here we have used slightly different variables, Garmin wristwatch, which is cheaper actually, compared to the earlier wearable that we have used. And we map it to hourly stress, pain, and craving labels and perform topological nonlinear analysis to capture chaotic process, how chaotic, unpredictable are stress, pain, craving within the last couple of days. And that tends to be particularly useful for solving this problem, which is whether these individuals might be misusing or more susceptible to misusing opioid versus just sticking to prescription use. And we have also used, like, all the people that in my world are using, the jumping up and down about LLM and all that. We did use some language model to kind of learn a representation from the EHR data, which was useful. But what is interesting is that more than that, the wearable data and then the topological nonlinear analysis of the wearable data was particularly indicative or particularly informative when it comes to misuse versus prescription use in this particular problem. All right, so here just more information about that. And the last bit of the presentation, I think, how we're doing in terms of time? Sorry, I'm not keeping track of time. We're probably...
Yeah, you have about 5 minutes left.
Okay, so I'm gonna wrap up the last bit and then I'll take questions. Last bit where we have looked into opioid, I mean, we also recognized, and it's kind of what Peter asked, that question, very relevant question, which is, we recognize that opioid impacts one's cognitive capabilities, right? Which is captured within this downward spiral kind of conceptual diagram of this OUD downward spiral. And we see that towards the end of the spiral, we see opioid attention bias pops up, insensitivity to natural rewards comes up, and then eventually it gives rise to loss of control over opioid use. And essentially, what we have demonstrated in a supplementary work, in a consecutive work, we have developed a model that would measure cognitive and physiological. It will model misuse risk with both physiological signals while a participant would solve cognitive tasks with a smartphone, right, or a digital device that will particularly capture attention bias and inhibitory control systems. The way it works, currently under review, the way we have used essentially dot probe trials, where the dot probe trial, and this work has been done in collaboration with Eric Garland. In the dot probe trial, what we show is that we show two photos on the screen side by side, a natural photo and an opioid-related photo. And we show it briefly for some time. And then we, after a while, a dot appears in either of these two sites, randomly, right, selected. and essentially then the user has to indicate where the dot was popped up, right, on the left or right, essentially to see whether our user is more accurately capturing the dot's placement where as it's appearing on the opioid side or neutral side, to capture this, attention biases, right? Because individuals who has a tendency to misuse, right, the dot might be more attentive to the opioid related photos. So that was the hypothesis on a high level. And in the go-no-go trial, we measured inhibitory control to show that whether the individuals has any kind of biases within the inhibitory control mechanism when looking at solving the kind of go-no-go trial in the presence of opioid-related photos versus neutral photos. And we captured reaction time accuracy and no-go accuracy. And essentially, the participants solved a series of tasks with a device, with a digital device. And what we found out is that the physiology and the cognitive task performance during the negative cues can be used to model misusers. We could classify prescription users versus misusers in that way. And basically, this directly addresses the challenge which is within the current screening method, which is essentially manual, and it asks manual self-reported based question as we identify whether these individuals are susceptible to OUD, which suffers from misrepresentation and lack insight into transition from prescription to OUD in an early manner. So overall, I think the high-level big picture is that we want to now create this closed-loop application that will on top of this rich set of digital biomarkers of opioid use, stress, pain, and craving states, and misuse risk score, almost like a daily misuse score. Can all of these digital biomarkers then help us to identify kind of intervention selection and intervention trigger mechanism through it could be either digital therapeutics or mindfulness-based intervention. But can we identify when and how to intervene for a particular user? And can you create such a closed loop system? And again, hopefully that creates us to create this dot in the northeast corner, which is kind of the desirable place that we want to be. Yeah, I think that's pretty much it. And the last bit that we have been working on is we have been creating a foundation model for wearable signal in the space where, let's say, two individuals in a family, right? Betty and Bill, I don't know, partners. Maybe Betty is more interested to look at physiological activity, where Bill is more interested, where Betty uses I don't know, Apple Watch, and Bill uses, I don't know, a Oura Ring, for instance, and models. They have two different interests. One is physical activity and sleep. And the question is, the current system is both of these two data, then sensor data is mapped to their individual cloud system, right? Oura Ring server versus Apple server, Betty and Bill then get some information back. Is it possible for us to create a foundation model on the crowd that will be able to, digest different sorts of wearable data, be it Apple Watch or Oura Ring, and is it possible for us to enable our user to kind of ask it questions, right? Query about stress, physical activity, mindfulness on the left side, which is Betty's interest. On the right side, maybe Bill's interest is sleep, I don't know, restless leg syndrome and snoring, making it up, right? Just made up example. And almost like in natural language, get those responses and reasoning so that they could adopt certain lifestyle changes. So it's something that we are still working on right now. There's a lot more technical details. I'll not have time, but I think I'll take question at this point.
Great, thank you. Is Claire still here? I think she may have signed off. But she asked in the chat about why do you think the social variables are not as useful in your model compared to kind of what people prioritize in the literature? I think this was for the middle section. Yeah.
Yeah.
For
Okay.
demographics,
The
yeah.
clustering. Yeah, the clustering thing.
Mhm.
It was not useful. I think maybe I misrepresented myself. I wanted to say that it was useful, but in conjunction with demographic information, like which includes social variables and stuff like that, right? Physiological factors is also very important. So by simultaneously in our model, we use demographic information, but also form this digital neighborhood clustering with physiological data as well. So it's a multimodal thing. So what we found out is that just demographic alone was not particularly accurate. So when we use both demographics and physiology together to form this cluster, our model was significantly better.
Okay, great. And Peter has another question.
Yes, inasmuch as you have referenced stress and pain as overlapping influences that each impact addiction, how can the relative contributions of each be sorted out and accounted for individually?
I see. Yeah, that's a great question. We have not accounted for that. We looked into as a process of three-dimensional data. So we looked at it that stress, craving, and pain all have joint effect, and we in our time series data we try to capture the cumulative effect. We have not necessarily looked into individual effect, but maybe in the future. That's a great point. Maybe that would be interesting to look at individual effect of all of these factors.
Fantastic presentation. Thank you.
Thank you.
And you posted a question in the chat. Would you like to unmute yourself and ask?
Sure. Thank you. That's really fascinating. So I think I was more curious about the implementation side. One is kind of the next step. Do you have any plans, or have you looked at actually using the wearables to detect the incidence of overdose? Because I know, I think it's called one of the companies that did blood oxygen. I think they had some patent issues with Apple, so they had that device, but I don't know, it kind of in the big landscape, do you have any plans in that route, or do you know of any other companies or teams that's working on this? And second, are you planning to take this out, a step further to actually implement it, working with physicians to carry out these fascinating models? Thank you.
Thank you so much. This is a fantastic question. This is exactly the type of things that are in my mind. I'm also in my career at a point where I'm thinking of more like commercialization and stuff like that. So yes, we do have a patent pending, right? So the idea was we have patented some of our digital biomarkers recently submitted for patent. It's not accepted. It takes a while, right? Necessarily, but it's there. It's full US utility patent. And right now we're thinking of pushing it to the next level for commercialization. It's actively in my mind. So that is very interesting that you asked this question. And the other thing that I wanted to mention about opioid over misuse, right? Sorry, let me go back to the
like
slide.
overdose when they actually happened.
Yeah.
Detecting during sleep or something when they are having a dangerous.
Right.
Yeah.
Yes, that is a fantastic question. So I think what we thought, my personal interest in, we have not done directly overdose modeling because collecting this type of data is challenging, right? How do you validate overdoses? There are approaches, I recognize that, but our approach is more was to help patient who perhaps are suffering from, right? Suffering from some of these challenges and want to get out of addiction, right? And what we identified in the US, there has been a big gap within the healthcare system, right? And I have highlighted that in my earlier slide with respect to the number of individuals that suffer from OUD-related challenges versus the individuals that are supported. So my primary interest is to create this closed loop system so that individuals, if the individual recognizes, yes, I have challenges, right? This is one of my challenges and I need to get over it. Can you create a closed loop system like this, right? That will use some of this digital biomarker and create almost like a recommendation system engine, right? For digital therapeutics or some form of interventions so that the individual will be able to easily get out of the addiction related challenges. So that has been my primary focus as opposed to overdose modeling, but I recognize overdose modeling is also very interesting But that hasn't been a primary focus in my research.
Yeah, that makes sense. Thank you. It's really great.
Okay, last call for questions.
Why is Betty utilizing? Peter, I didn't quite understand this question.
Betty
Sorry,
has a left hand that's attached to a right arm. That's rather unusual.
AI hiccup, exactly. I created with ChatGPT these two photos. There might be some watermark here, AI, or at least I could see it on the big one. Yeah, so AI hiccup, hallucination.
Okay, great. Well, let's all thank Dr. Rahman for his talk today. I think this was very provocative and interesting, and great to see what directions we might go in order to not only track people, but predict what their behavior might be like in a way that might facilitate intervention. So thank you very much.
Thank you.
Thank you. The pleasure is mine. Thank you so much for inviting and allowing me to speak to this fantastic community.